Alright guys, welcome to TheraX2. We're going to do things a little bit differently in this course where you are going to have some video lectures to watch beforehand that I may or may not supplement with some YouTube videos or different podcasts from different resources that have been helpful to students in the past, and articles or your textbook. Your textbook is always going to be a resource for this course. However, your textbook is very deep in is very in-depth, and so the goal of this course is to guide you through the resources in a way that you can navigate them to discern what information you need, what information is beyond your scope, what information you can apply in the clinic, and what information you need for licensure, and be adequately prepared. So the syllabus is available online. I'm not going to go through the syllabus in here just because that would be a little redundant for something you can access on Canvas. But your course assignments, the goal of this setup is that the majority of your at-home work will be reviewing the material before you come to class. And so you'll be watching these videos or any of the additional resources, and then when executed correctly, you guys participate the way that we need to, your work and assignments will primarily be performed in class, and so you shouldn't have much outside of class homework time other than preparing for the next lecture. We do have some adjustments in the course times. Obviously, Monday already started off with a course adjustment for our day of service at the golf outing, but then we also have student observations on June 5th, and Miss Scott will be finalizing those placements soon so that I can let everybody know when and where they will be going for their student observations. You will have an assignment associated with that student observation time, so that way you can make the most out of that experience as well. We will be going to hanger prosthetics on June 13th as part of our amputation and prosthetics lab, and so be prepared for that schedule adjustment. And anything else that isn't available on the course schedule, we will talk about. But go ahead and take a look at that on Canvas. Functional assessments. So if we look at our textbook, R.O. Sullivan, Schmitz, and Polk, Chapter 8 is what we're looking at, and we want to talk about what is function. And function is what a person needs to be able to do, right? That's their function in society, be it as their independent roles within their house, their roles within a group as a family structure, their roles within a group within the community. Function is anything that a patient needs to be able to do. And so the end goal of any rehab program is going to be to restore function. So functional assessments are used to determine a patient's level of function and how much intervention they require to restore their prior level of function. And a functional activity, I think, it kind of goes without saying, but it's any activity that is needed to be performed in order to perform a functional task. And so we look at our functional activities like our transfers or our bed mobility, but it's also being able to go up steps and anything that promotes function. So we look at function through the ICF. Health is defined by the WHO as a stage of complete physical, mental, and social well-being, and not merely the absence of diseases and infirmity. And so health is looking at a patient as a more whole picture individual and trying to promote their best placement, not only in a biological position, but also the psychosocial position as well. And so we look at the biopsychosocial model through the ICF. The ICF is used by the WHO and is the basis for the ICD-10, which are our diagnosis codes. So reviewing that, function is defined as an umbrella term encompassing all body functions and structures, activities, and participation, whereas disability is a term that encompasses impairments in body functions and structures, activity limitations, and participation restrictions. The ICF consists of two parts. The first part describes components of function and disability in the context of health, and the second part describes contextual factors which may interact with components of the first part. And so again, with the ICF looking at the biopsychosocial and the whole person within their environment, we have to consider both parts of the ICF and what our patient's needs are. Remember that an impairment is what the patient has difficulty with at a tissue-based level. So it's a problem in body function or structure. So we look at muscle weakness, improper muscle firing, range of motion deficits, coordination deficits. Those are impairments. Those are things that are happening more at the physiological level. Activity limitations and participation restrictions come into what the patient can do. And so those relate more to function. So impairments cause restrictions in function, and those are our activity limitations and participation restrictions. So our activity limitations are problems with execution of a task or action by an individual, and these are usually the things that we consider them being able to do within the home. And our participation restrictions are the problems with an individual's ability to engage within society, within the societal roles important to the individual. And so this is what we consider them being able to do within the community. So this is just a review picture of your ICF model, looking again at how all of these things interact with one another to define the person's level of health or disability. Looking at the contextual factors, part 2 represents the complete background of an individual's life and includes factors that may act as facilitators or barriers to the components of function. So what contextual factor may be considered a barrier to function? Well, if we think about this in the context of a patient, stairs can be a contextual factor that are a barrier to function. A person who lives on a single-story home with no steps to enter and has their bedroom, bathroom, everything access on the first floor does not have that environmental barrier, whereas a person who lives on a second-floor apartment and needs to be able to get upstairs to be able to get in their front door does have those contextual factors. Contextual factors that may be considered a facilitator to function are going to be what level of family support the patient has at home. Somebody who lives alone does not have the contextual factors present to have a supportive home environment where they can have a caregiver present as needed, versus somebody who lives within a full family structure where there are multiple caregivers who would be able to be present. Those two patients are going to have different discharge dispositions the same way that the two patients in the different home setups, as far as the stairs go, are going to have different discharge dispositions. And we have to remember that these contextual factors heavily influence what we are able to do for our patients, what goals we need to achieve for our patients, and what settings are most appropriate for our patients. So looking at the difference between our environmental and our personal factors, our environmental are external to the individual, and these can be positive or negative, and they include things such as sidewalks, wheelchair ramps, handicap accessible bathrooms, natural disasters, technologies, attitudes of others. And then our personal factors are going to be features of the individual that are personal to that particular individual, and so they're going to be unique to the patient and not likely to be as common compared to another patient as an environmental factor. Again, they can be positive or negative, and examples of these are going to include age, gender, race, motivation level, cognition, attitudes of self. So when we talk about functional assessments, we're looking at an objective analysis of patient function in order to focus on identifying pertinent activities and measuring the patient's ability to successfully engage in those activities. Functional tests and measures yield data that can be used as baseline information for setting functional goals. Indicators of a patient's initial abilities and progression towards more complex functional levels, criteria for placement decisions, such as whether or not the patient needs inpatient rehab, whether or not they are safe and appropriate to go home, manifestations of an individual's level of safety to perform a task, or the risk of injury with task performance. And this is something that we can use to not only justify therapy services, but it can also be used to educate a patient on why they need to avoid certain things when they are not wanting to heed other advice. And then they can also be used as evidence of the effectiveness of an intervention, whether that's to the patient, to the payer, to the surgeon who initiated the treatment or the plan of care. But they'll provide that evidence and baseline, because how do we know somebody's improved if we haven't done anything to measure it? Functional assessments can have two different perspectives. We can look at what the patient's habitual level of ability to perform a task or activity is, or we can look at what the patient's capacity to perform a certain task or activity is. So when we're looking at habitual level, we're looking at their overall average performance. What do they do on a regular basis? When we're looking at capacity, we're looking at what is their absolute best, what is the maximum that they can do. And depending on what goals you have for your patient, what demands you have for your patient, there's going to be a different application of each of these perspectives. So some basic considerations for functional assessment testing include that the setting must be conducive to testing. So we've got to have it free from distractions, provide enough space, have all the available equipment, all of those things. Instructions for functional assessments should be clear and unambiguous, and most functional assessments have very specific instructions. You are not supposed to ad-lib them or make them up in your own words. They're supposed to be clear and precise because they need to be standardized, and we can't compare them to our normative values unless they're performed in a standardized fashion. Testing may be biased by patient fatigue, so the therapist should know the patient and how they function throughout the day so that we make sure that we capture the right performance. If we know that a patient has activity tolerance limitations, we don't want to necessarily test them before they've done any interventions if we're trying to advocate for their need for more therapy. We may need to have them be a little bit more fatigued before we perform the assessment and show a true picture of what their functional level is as the day progresses and they have more activities that they need to attend to. Testing should occur ideally at an initial evaluation, and then retesting should occur at regular intervals throughout the episode of care and at discharge in order to document patient progress. So while you as the PTA may not be doing the initial evaluation and determining the functional assessments, it's important that you know how to perform them and how to document them for all of the reassessments and discharge. So beyond the two different perspectives that functional assessments can look at a patient from, we also have two different types. We have performance-based tests and self-reports. Performance-based tests are going to be when the patient is actually performing something, and self-reports are going to be what the patient says they can do. So for performance-based tests, the activity is observed performing an activity. Conditions and environment should mimic the patient's environment at home as much as possible. Instruction should be specific and detailed and standard for the administration of the test. Examples of performance-based tests include the 6-minute walk test, physical performance and mobility examination, functional reach test, time get up and go test, physical performance battery test. A lot of the ones that we've already looked at in class are performance-based tests, and that is something that we need to be familiar with being able to implement with our patients. Self-reports must use clearly worded questions without a language bias. If an interviewer is used, ad-libbing is discouraged as it tends to bias results. So basically that means if you are reading it to your patient, don't put it in your own words. Read what it says. Give them the unbiased version of the question. Self-reports may measure habitual performance of a skill or patient confidence in performing a skill. The time frame of reference must be clear to the patient, so we have to tell them as they're answering, are we looking at their performance within the last 24 hours, the last 2 weeks, the last year, the last month? What is that time frame? And it has to be clearly stated to the patient. And we also want to make sure that they use that same timeline when we do any follow-ups because that's going to help us track their progress better. These are going to be a lot of the ones that are given like at the front desk in an outpatient clinic where the patient's filling it out for themselves before they come back to the therapist, but they still need to follow up with those self-reports. Examples are going to include the optimal, the NDI, the ODI, the quick dash, the LEFS, and the PSFS. Instrument parameters and formats. So good functional outcome measures should not have floor or ceiling effects that poorly reflect patient progress. So a floor effect and a ceiling effect are going to be that the test either isn't hard enough or is too hard to truly capture whether or not the patient is at a deficit. And we'll talk about those a little bit more in detail a little bit later. Descriptive parameters such as dependence and difficulty should be well defined, and if you look on page 302 in your textbook, box 8.1 shows frequent terms used. You should be familiar with those before clinical, and so that's going to look at different levels of independence as well as how we can grade balance and what those all mean, and it's standardized across the profession, so that way when you document it, it means the same thing to you as it means to the next person reading it. And when you read a note, what they document as the patient's functional level means the same thing to you. Quantitative parameters like time skills, measures of distance walked per set amount of time, those things should all be utilized to help standardize the information. Any quantitative measures are typically outlined in a functional assessment, and so they can be standardized, but if you do anything to modify it, you need to document that modification. Response formats can be nominal, ordinal, interval, and ratio. So our nominal responses are going to be things like checklists, such as able to do or not able to do, incomplete or complete. Ordinal is going to be a descriptive or rank order scales, such as no difficulty, some difficulty, always, sometimes, never, that range of options. Our interval responses are going to be summary or additive measures that grade a series of skills and award points for part or full performance and give a score out of a total possible. So when we think about like our DGI or our FGA, when we were scoring each one of those items for points and then totaled that, we're looking at our Berg, and that gave us our fall risk assessment. Those are interval ones. And then ratio is a visual or linear analog scale, such as the VAS for pain. And so ratio is probably the most commonly used just because of the pain scale. So when we interpret test results, the test results must be interpreted correctly in order to establish and revise the goals and plan of care and measure patient progress. If retests show a diminished performance, the therapist must try to ascertain the cause of the decline. So if we see that a patient has done worse than what they have done previously on the same functional assessment, whether that's in the same session or weeks apart, we need to determine why, and we need to be able to document it. So how do I choose a quality test? APTA's guide includes almost 500 tests in the catalog of tests and measures, and we need to consider the reliability and the validity of the test. So reliability tells us whether or not an instrument, when used repeatedly or by other people, is going to consistently measure the same thing. And so the strict definition says that a reliable instrument measures a phenomenon dependably, time after time, accurately, predictably, and without variation. So we have a couple different types of reliability that we want to look at. Test retest reliability. When a test has high test retest reliability, the test will not show change when none has occurred. So if I give a test and then I give it again, there's not going to be an improvement unless the patient has actually demonstrated improvement. Intra-rater reliability, when the same therapist repeats the test, they will get the same result consistently. And so that's going to differ from inter-rater reliability, where we're looking at when multiple therapists administer the same test, they will get consistent results across the board under the same conditions. So intra means that when I perform it, I can consistently perform it again and get the same results. Inter means when I perform it compared to when one of you performs it, we can consistently get the same results. And then we can also look at reliability coefficients. So a reliability coefficient less than 0.5 is poor, 0.5 to 0.75 is moderate, and greater than 0.75 it has good reliability. And it is very important that you guys know the difference between these different types of reliability and what reliability indicates about an assessment. So where reliability asks, can we get consistent results? Validity says, do the results measure what we want them to measure? Are they about what they are supposed to be about? And so validity is a multifaceted concept that includes whether an instrument designed to measure function truly does measure what it's intended to measure, what the appropriate applications of the instrument are, and how data from the test should be interpreted. We've got a couple different types of validity that we need to be familiar with as well. So face validity is saying that the test measures what it purports to measure. It's going to measure what it says it will. Content validity is whether the instrument measures all of the important specific dimensions of a function. So content validity is really just about how all-encompassing the assessment is. Criterion-related validity says an instrument is tested against a gold standard and gets similar results. So criterion-related validity is used basically when we're assessing new assessments. Does it line up with what we already use as our gold standard for this? And then concurrent validity is the degree to which two different instruments agree in results. And so do they get similar answers or predictions for the patient? Sensitivity and specificity are also important concepts, and they are related to the statistical analysis of the functional assessment. So sensitivity of a test refers to the proportion of individuals with a limitation in function who are correctly classified. Sensitivity is an indication of how well a test identifies persons who should have a positive finding on a test. So we want our true positives. A test that is highly sensitive is going to correctly identify our true positives. Specificity of a test refers to the proportion of individuals who do not have limitation in function who are correctly classified. So this is going to identify our true negatives. Somebody who gets a negative result in a highly sensitive test should truly be negative. Both sensitivity and specificity are values from 0 to 1, and ideally we want them to be as close to 1 as possible because that would demonstrate having a high sensitivity and a high specificity. We can use sensitivity and specificity to also determine positive and negative predictive values. So our positive predictive value is the proportion of people who have a positive finding on a test who actually have a limitation in function as classified by a comparison test. And then our negative predictive value is the proportion of people who have a negative finding on a test who do not have a limitation in function. So our positive predictive value correlates more with our sensitivity, and our negative predictive value correlates more with our specificity. And so an acronym that you can use to help remember this and determine whether you're using a test to rule in something or rule out something is going to be SPIN and SNOUT. So SPIN, specific tests, rule in, tests with high specificity. A positive finding helps to rule in the condition. SNOUT, tests with high sensitivity. A negative finding helps to rule out the condition. Likelihood ratios, the sensitivity and specificity values may be combined to obtain a likelihood ratio, and they may be helpful in determining how much the test result influences the identification of a patient's condition or identification of a limitation in function. And so we care about sensitivity and specificity and likelihood ratios because if a test says that it's going to predict for something, we want to know whether or not it can accurately predict for something. You know, if we give a patient a Berg assessment to predict for fall risk and it doesn't score them as a fall risk, but they in fact are a fall risk, it's not a very good test because it doesn't have a high specificity. If somebody takes a pregnancy test and they get a negative result and they are not in fact negative, well, that specific pregnancy test didn't have a high sensitivity, and so it was not a good test and it affected the likelihood ratio. So we want tests to be specific and sensitive because we want them to do what they are supposed to do. When we look at changes in functional assessments or any outcome measure, we want to look at meaningful change. And functional measures should be sufficiently sensitive to reflect meaningful changes in a patient's status. We want to be able to see an improvement when we do something to make an improvement. The change should exceed the minimal detectable change, which is also known as the MDC, and that's the smallest amount of change in a measurement that exceeds the measurement error of the instrument. So every instrument is going to have a measurement error, and that's going to be kind of the difference in what human influence can cause in application of that test. So if we look at range of motion testing, goniometric measurements have a standard error of measurement of 3 to 5 degrees. So that means between when I measure a patient one time and I go back 30 seconds later and I measure them again, or somebody else goes back and measures them and we consistently do that, we're all going to be somewhere within 3 to 5 degrees, but we're not probably all going to get the exact same number. And that has to do with the standard error of measure. So when we look at the minimal detectable change, that has to exceed the standard error of measure. So for a range of motion measurement, the minimal detectable change would have to be at least 6 degrees because that's the smallest amount of change in measurement that exceeds that 3 to 5 degrees of standard error of measure. The change should also exceed the minimal clinically important difference, and this is different from the MDC because it has to do more with what affects the patient's function. And so a minimal clinically important difference relates to what amount of change in this test needs to be seen before a patient sees a positive impact in their functional ability in day-to-day life. The MCD or MCID values are specific to exact populations in the study, or MCD or MCID values are specific to the exact population studies in the research. So when they look at these values, they're looking at a specific patient population. And so we can't necessarily apply them throughout all patient populations. We have to look for an MCD or an MCID specific to the test that we are using and the patient population that we are applying to it. Remember to consider the change in the context of a floor or ceiling effect. So if a test has a floor effect, it is not going to capture my lower level patients. It is going to score them too low to even get them to reach the test. Think about giving somebody a gait-based fall risk assessment when they have difficulty with static stance. The Berg would be a more appropriate test for that patient than the DGI because of the floor effect. Ceiling effect is going to be when my test caps out being able to capture somebody's performance. So if I gave any of you guys the Berg, you are likely not going to show a lot of deficit on that test, and you would need a higher level assessment like the DGI or the FGA before I would see anything. And so that's where we need to look at the difference in our assessment application and whether or not it's appropriate for our patient population so that we can minimize the effects of floor or ceiling effects. And then again, we talked about this earlier, but it's important to note that a decline in functional status compared to previous sessions should result in the therapist ascertaining the contributing factors and documenting those with the results in the treatment note. So if something isn't progressing in the right direction, figure out why and document it. Floor effect versus ceiling effect. So floor effect occurs when a significant number of patients score the lowest possible value and indicates the measure cannot distinguish levels of impairments for patients with severe disabilities, like we just talked about. Ceiling effect occurs when a significant number of patients score the highest possible value and indicates the measure cannot detect further improvement by highly functional patients. And so we want to make sure that we avoid our test falling victim to either one of those. Key differences to look at: the floor effect. So an example would be a mobility assessment where patient has a limited function of all scores of 0, and this limits the sensitivity for patients with severe impairments, saying that the test is too hard for the patient's level of function. Ceiling effect is a cognitive test where high functioning patient scores the maximum value, and this prevents accurate evaluation of patients with high capabilities, and this test would be too easy for the patient. So the key thing to take away for this is that you'll see a floor effect if the test is too hard for the patient. You'll see a ceiling effect if the test is too easy for the patient. It matters because both effects reduce the tool's ability to measure patient progress and distinguish subtle changes, and choosing the right tool avoids inaccurate assessments and provides more meaningful data. So if you go ahead and take a look at box 8.5 on page 308 and look over those critical questions to ask in selecting an instrument, those are just helpful guidance questions in selecting the most appropriate functional assessment tool. A lot of times that choice may not be given to you because it might be determined as part of the initial evaluation, and it's your responsibility to follow up with it. But if you notice especially a ceiling effect coming into play with the original functional assessment, that's something that you need to be able to communicate to your supervising PT, make the appropriate adjustments. So functional assessments can look at one direction or it can look at a scope of things, and those are called multidimensional instruments. And they measure a combination of several domains of function, whereas a single dimensional measure looks at one specific type of function. Examples of multidimensional instruments include the impact or SPADES, the Outcome and Assessment Information Set, also known as OASIS, and the SF36, and examples of those are in your textbook should you want to take a look. So the impact or SPADES, also known as the GG modifiers, replace the FIM. And so that is one of the presentations that you guys have for your group presentations. And that group, should you have any questions, please come talk to me. Information is a little tricky to find. It's out there, but it can just be difficult because it has so many different names. But either way, the impact spades and Oasis include more ADL items than the SF36. The SF36 includes work performance, where the others do not. They're more strict functional mobility. The impact spades was designed for use across all settings and was transitioned to from the FIM. The Oasis was designed for home health agencies, and the SF36 generally focuses on younger adult populations in ambulatory care or outpatient care. So Oasis is used for the assessment of adults in home-based setting. If you go into Home Health Part A, you will most certainly come across Oasis. Home Health Part B tends to be that kind of outpatient-oriented home health care, and so they do not have the same documentation requirements. But anyways, in January 99, home health agencies were mandated to use the Oasis, and the current version is the Oasis C. It looks at socio-demographics, environmental factors, social support, health status, and functional status. The ADL IADL section is comprised of 13 items, including grooming, dressing upper body, dressing lower body, bathing, transferring to the toilet, toileting, transfers, ambulation, locomotion, feeding, meal preparation, ability to use the telephone, prior functioning, and fall risks. They use both nominal and ordinal scales to measure, and you can see an example on page 311. This is important to note that it is all components of home health being able to contribute to the Oasis scoring. And so if a patient is receiving home health nursing, home health OT, and home health PT, each can score for their own sections and document that they did not observe for things that are being scored by another discipline. So your functional outcome measure assignment, that is something we are going to do in class. Don't worry about this slide. You will also be given your presentations on functional assessment measures. You can take a look at that on Canvas should you want, but we will go over that in class as well. And you will have a case report assignment that we will be going over, and the goal of that is to understand case reports better, for how to read them, where to find them, how to assess them, because part of what's going to happen in your clinical rotation is that you are going to have to do a case report on one of your patients. And so we will do an assignment in preparation of that to familiarize yourself. So that is it for the functional assessments lecture. Please come to class prepared for a brief quiz over this material and any questions that you may have over this content, and prepared to do these assignments.